there. Welcome to the Pelvis Project podcast. I'm Megan.
And I'm Roxy. We're two pelvic health experts brought together by passion for our careers, entrepreneurship, motherhood, and the desire for intentional relationships.
Join us in our mission to spread pelvic floor awareness and start conversations surrounding the truth behind genuine health, imperfect wellness, and joyfully navigating life. We are so glad you are here with us.
Let's start the conversation.
Hello, Roxy.
Hi, Megan.
We are back and the sun is out. We are recording not at nighttime. So it's a win for us today. We are going to jump right in as this episode is near and dear to both of our hearts because we see and treat a lot of patients that have either not been diagnosed or diagnosed with endometriosis. And March is Endometriosis Awareness Month. And so we just wanted to take a little bit of time, kind of speak into endo in hopes that if you are somebody that are dealing with some of these symptoms or cluster of symptoms, that hopefully you can find a provider that will look a little deeper for you.
So just to kind of start off with, a lot of times we just associate endometriosis with bad periods and cramping and pain. And so just a couple quick stats that go with this is that 1 in 10 women worldwide have endometriosis. And that's quite a lot. Like you think about your friend group.
It's a lot.
You know, like one of you probably has them, one or two there. What's shocking is that the diagnosis takes 7 to 10 years on average. And so I think that just speaks into maybe how well we're listening to people or how well we're diving into initial complaints. And that's because many patients are actually told that their pain is normal or that with their period, they're supposed to have pain and cramping. And so this complaint, a lot of times just makes a woman look extra or kind of wimpy or whatever. And they aren't actually heard a lot of times initially. And that's why that takes so long.
Yeah, absolutely. I mean, we see this a lot every day, feels like in the clinic.
Mm-hmm. Yeah. And so basically what we see then as pelvic health therapists, we get to spend a little more time with these people while we're working with them. And so we see the impact on the day-to-day. And it's not just the pelvic pain, but then there's a lot of ripple effects that go through the entire body. And we're going to unpack that today.
Yeah. So I have a handful of patients that this, it's like as you start to see more and more people and care for more and more people with endometriosis, you start to notice the ripple effects that Roxy talked about. But we want to make one thing clear here because it's still wild to me that we kind of think about endo as just like it's something that just affects the reproductive organs. But endometriosis is a chronic inflammatory disease where tissue similar to the uterine lining grows outside of the uterus. But this is a chronic, full-body inflammatory disease. So I want to make sure that we get this nailed down, everyone. So they have found this tissue in the brain. They found this tissue in the diaphragm. This is something that affects the whole body. And even if maybe where your lesions is in the pelvic cavity, it's a full body inflammatory disease. So anytime I have somebody come in that has this diagnosis, that's one of the first things that I counsel on is we need to be looking at this as an autoimmune type of response, and we have to treat it as such. So just doing one thing isn't actually going to be just the one thing. We have to do multiple things because it's affecting your whole body. So common locations where we see this tissue is ovaries, fallopian tubes, bladder, bowel, pelvic ligaments, diaphragm, nerves. But again, they have done studies where we're finding that this tissue in multiple different places. So the key point here is it's not just a gynecological condition, it's a whole body inflammatory disease. So can't say that enough. So important mechanisms to kind of think about with that is we have this chronic inflammation, we have immune dysfunction, the nerve sensitization starts, we have a hormonal influence, and then we have pelvic floor muscle guarding. So when you think about it like that, it definitely puts into perspective why when you're working with somebody with endo or suspect this, you need to have a multidisciplinary team to really get the best benefits. And I've just seen some really amazing teams develop with some of my patients, with different doctors in other states and here locally with like getting some help. We'll talk a little bit more about this, but like there is a difference between like your regular OBGYN and seeing an endometriosis specialist or surgeon. So yeah, it really is a lot more than what people think.
Sure. So, kind of going back to that, piggybacking off what you said, and to repeat what I said earlier, is that it's not just painful periods. I think
Hmm.
that just people think it's umbrella term for pain. And so, with what Megan just said, that in our view, and with that as our new lens, I want you to think about the symptoms that are often missed that people don't realize go along with this. And so, when endometriosis exists, symptoms can include what we notice the most is probably, or what we commonly associate with is that severe period pain.
Hmm.
But also, these gals are having pain with ovulation. They can usually know right when they ovulate, they have significant pain with that. They're having pain with sex. They're also having things like bladder pain, bowel pain. You heard Megan mention that. That's where some of this tissue can definitely grow. And even if it doesn't grow directly on that, that can cause restriction and adhesions to be involved in that. And so anytime think of how often you use the restroom. And if that were painful all the time, you can start to maybe understand and appreciate how impactful this is for these gals. Those were just the pelvic symptoms. Let's kind of zoom out a little bit. Whole body symptoms. And remember, Megan talked about this was more of a systemic pathology. And so the whole body symptoms include things like fatigue or bloating. Sometimes though it gets coined like endobelly, because that bloating can be so severe. But also things like nausea, headaches, back pain, hip pain. And then Megan hinted at that we work with this in the fertility world, that this can a lot of times have a high association with infertility, recurrent miscarriages, painful ovulation, and then even that pain that can even radiate down the
Hmm.
legs. And so when we are thinking about this, we have to appreciate that any pain that interferes with life is not normal. So if it's causing you to have pain with your bowel movements and when you're
Yeah.
peeing, like that is not normal.
Right.
Or, intimacy with your spouse or fitness, recreation, just enjoying the things in your life. If you think about those symptoms I just listed, those are all very impactful when it comes to just quality of life. And so that's never normal. And when maybe would just hop back a little bit. When we talk about period pain, that type of pain should be managed with one ibuprofen. And so,
Yeah.
like, if there's a pain that is interfering with your quality of life, that's beyond that one ibuprofen at that point. And so we know this needs to not be viewed as PMS or, just like some typical abdominal cramping that does come with our cycles.
Yeah. And I think just encouraging people in that sometimes because we didn't have a lot of conversations about this with our mom when we were younger. And so sometimes people just don't really even know what's normal. And so we think that it's normal. It's kind of like people think, well, I guess it just hurts with sex. It's the same thing. Like, I guess this is just how it is with my periods. So we really encourage anybody listening to this right now, advocate for yourself. If your periods are taking you down to where you're having to not be able to go into work or, a couple days, it's like you cannot function, that is not normal. And I just really hope that a lot of women hear us on this. And the other symptoms, as far as like fatigue and bloating and nausea and headaches and back pain, all of that, like you can have, that's the interesting thing about endo is if you see a specialist and you get a grade for if it's grade 4 endo or 1, it's this spectrum of you could have essentially like a 1, grade 1 endo, if you will, and have extreme symptoms. And then somebody that's like, oh, I had stage 4 infiltrating whatever endo and not have that much period pain. I've had people silent endo that have no pain at all. So this is where it does get tricky, but trying to find the right providers that will look and dig and also not just say things like, well, we really could only know if we do a laparoscopic procedure and you probably don't want to do that. Well, no, maybe you do. Maybe you do. So let's not gaslight people into being like, okay, let's not make this a bigger deal than it needs to be. Let's be proactively looking because if it is affecting your life that much, then it needs to be addressed. So why diagnosis takes so long. Let's talk a little bit about that. So the average delay is 7 to 10 years. And so now, just from what I just said, you could probably understand why there's some situations where it takes 7 to 10 years, because it's like where one thing might show up and then we find out something else. And it's just this pattern that's really difficult to navigate. And you just get pushed off, you're not listened to fully. So reasons it seems like this can kind of happen is period pain can kind of normalize for a little bit. Like you could be having trouble and then you're okay. And then you have trouble and you're okay. So then you're almost like questioning yourself. Should I say something? Should I not? Another reason why this can happen is lack of provider training. This really is something like not everybody has the same level of education on endo, or maybe it's just not flagged in the forefront of their mind. And then imaging often misses endometriosis. So you're not going to be able to go get an ultrasound and then be able to see endometriosis. It's just not going to happen. And so if you're having pain and they say, let's do a sonogram and look, and they say, well, it looks okay. Well, that doesn't mean anything. You can still have endo. And then patients are told it's anxiety or IBS. So a lot of the issues with bowel pain get chalked up to this IBS thing. And that's something I think here recently, like we really need to be paying attention to with our female patients. And then hormonal birth control masking symptoms. So if often you were young and you started having like bad periods and you were put on the pill, then it masks all these symptoms for years and years and years. And then like you get off the pill, maybe you decide you want to start to have a family, or you're just ready to be done with the pill. And all of a sudden it's like, what hits the fan, and we've got to be looking about what's really going on. And quite frankly, like it's better to know. So those are some reasons why it can delay, because it gets so strung out over a long period of time, especially like we just mentioned, if you have that hormonal birth control in there, because it might quiet things down for a while. The gold standard, we mentioned imaging often misses endometriosis. The gold standard is a laparoscopic surgery with excision by a specialist. Okay, so our OBGYNs, they're fantastic, but they are different than a endo specialist, just like a dentist is different than an orthodontist. So let's keep that in mind, okay? And that doesn't mean there's anything, this is not bashing one or the other. This is that they are not the same. Okay, so there's an important distinction that we need to talk about, excision versus ablation. So excision surgery has significantly better outcomes. And an ablation is like the burning. And so you want to make sure that the burning of the lesion. So that you want to make sure that when you are looking into this, that whoever is going to be doing the procedure is trained in this most like the distinction and like the best outcome of having excision.
Yeah. And I would say so a lot of times we see OBs are trained to do the ablation piece, but then the excision specialists, the endo specialists are doing the excision piece of that is a lot of times what the trend is that we're going to see.
Yeah. And with that, I have definitely seen some OBs that have, done some training with excision. And I know that are saying like, I do this. And that may be the case. But in our training and the specialists that like learn and hear it from, they have a level of training where their eye is trained to see some of this tissue in places that is often missed. You see time and time again where somebody was told like, nope, there's no endo. And then they see a specialist and they in fact do. And so that's again why this takes so long to get diagnosed, is because imagine if you were told like, nope, sorry, you don't have endo. And then you have all these symptoms and then decide to circle back a few years later. And someone's like, yeah, I found it here, here, and here. And some of the videos you see are really fascinating where specialists will say like, this person was told they didn't have endo. And then they show the surgery, they show going in. And they're like, they show the identification of those spots. So it's just something to think about. And hopefully it's just knowledge of like learning what to ask before you jump into something with a provider.
Sure. So we're going to pivot here, and not pivot, but just go down another topic of the pelvic floor connection. And this is where Megan and I's bread and butter are. So this is what we see in the clinic often. And so what we see is, obviously we're talking about this excision, ablation, all these things. that's not really our
Yeah.
bread and butter. We can't fix endo in pelvic floor
Right.
therapy. We can't
Right.
remove it. We can't eliminate it.
We can help manage it.
We can help manage it, and that's
Yeah.
where we see really good outcomes. But what we identify is that endometriosis often leads to things like pelvic floor muscle overactivity because their people are in chronic pain, so their
Yeah.
pelvic floor is going to grip and guard, which leads into the next, obviously, of muscle guarding, nerve sensitization, and then central pain processing changes where the body is in protective mode all the time. So the moment that there's a hint of pain, the body overprotects essentially. And so we're finding there's a lot of hypertonicity then in like the levator ana. It's just part of the pelvic floor. Some of those muscles, some of the even the hip muscles there have trigger points in them, like the obturator internus. We're seeing nerve irritation, specifically in the pudendal nerve, and then other things like abdominal wall restriction. Because when think of when any of us are in pain, we kind of want to get into that fetal position. We kind of want to curl, embrace, and guard. So those abdominal, like the abdominal shorten, plus then the endo's right on the other side of that usually. And so then those restrictions further fuel and they just feed each other. And then also some scar tissue restrictions. If anyone's had any kind of procedure, like whether it's an endo related procedure or any, like someone had their appendix taken out or whatever that is, or maybe
Yeah.
there's a C-section, like depending on where people are in their lifespan and what experiences they've had, there can be a lot of scar tissue restrictions that we see that those are the areas that as pelvic floor therapists, we can work into. And so we're going to do that by addressing muscle tension and getting those muscles back to a healthy baseline as much as possible. And then working on nerve mobility, we're going to work on those fascial restrictions where we see that the endometriosis is causing like adhesions and a winding up tight of the tissues within the abdominal cavity and the pelvic cavity there. And we're also going to work on breathing patterns and nervous system regulation because of that high fight or flight response that tends to happen when we experience chronic pain. And if you really want to deep dive into that, go back and listen to our most recent interview series with Paige Genova and talking about pain reprocessing. These people do fabulous with this pain reprocessing because their brain has adapted to pain for the worse. Basically, their brain starts to respond in this chronic cycle of guarding, and so we work on that nervous system regulation and some of those reprocessing to help their body not tense up and want to curl up in a ball and hide every time there's a hint of this pain coming up. And so that's just kind of a tidbit or an overarching view of the things that we are able to do with pelvic floor therapy.
Yeah. I just value I really am always honored to be on somebody's like health journey with endo. And it's so rewarding because when you are doing this abdominal work and the visceral work and someone's so painful and so restricted, and as your patient and you work with the body and work through that, to be able to see the improvements in that and like so much less pain. And maybe they still have flares, they still have pain, but we have this like dialed down a bit where they have days where like, okay, I was able to do XYZ. And it's just so like, I mean, I never, or early and probably both of our careers, like I didn't ever really even track endo as like a pelvic floor. I think I had a couple people, and to be quite honest with you, I didn't quite really even know what to do. And now if I strictly saw endo patients, I would be happy, because not happy for them, but happy to help, because if you can get somebody on the right track, again, we're not treating it, we're not making it go away. We're figuring out the best way how to manage it so that your body can get back to some sort of functioning level. And again, pain processing has so much to do with that. So let's talk a little bit about whole body treatment approach with this. And this is, again, this is where I'm like, I love that we are able to provide care the way that we are in our clinics, because this is why we became physical therapists. Endometriosis treatment should be multidisciplinary. So let me tell you that if one person acts like they can take care of it, then find somebody else. A comprehensive team might include excision surgeon, a pelvic health physical therapist, or occupational therapist, nutrition support, mental health support, pain management, and hormone specialists. So you got multiple people on the team here. So an important message with this is there's not one single magic fix. Endometriosis requires a whole body strategy. So when I'm starting to work with somebody, of course, yes, we are first addressing and assessing the pelvic floor. Then we're also looking at the nerves, the nervous system, just like Roxy said. But often what then we have to do is we're like, okay, so we're helping guide and give advice on when we're being asked questions about hormones, birth controls, who should I see, what should I do, what questions should I ask? We're there to help coach and be an advocate to help because a lot of times individuals have dealt with this for so long, you tend to almost gaslight yourself. So we're there to be that sounding board like, hey, no, ask this. How are you feeling about that? If they said this. So we are acting as that support and then getting you lined up with maybe a dietitian or nutritionist or, you know, honestly, some of the newest stuff out to help with endometriosis. Again, this is not medical advice, but a medication called low-dose naltrexone. This is something where people are been like, I haven't been told about that. And then they bring it to their doctor. And some doctors honestly aren't even doing this because they are just unsure about it. And others are like, oh, yeah, absolutely. It's actually been used in pain management a lot more here recently. Microdosing of GLP-1s has been game changer for a lot of people with endometriosis. And you're not maybe going to hear that in the standard system. And so to just be given options of like, hey, these are some things that we're seeing actually being very helpful. Doesn't mean you have to do it, but it plants the seed to be able to go research it yourself and find out. And that's why you're having a whole body team, which I would add to that list, some sort of functional provider that is willing to kind of look more like deeper at some other chronic inflammatory things. So I think ultimately, if you've been told that your pain is normal, it's not. And if you've been dismissed, keep advocating for yourself and know that there are people like pelvic floor therapists like Roxy and myself and a lot of our colleagues all over the country that have the time and the ears to listen and the wisdom to know how to help direct. And we're happy to link you up, or if you have questions, obviously send us a message. But there are providers who understand endometriosis and take it seriously. If you've heard this and you're like, oh my gosh, yes, this is me, or I know somebody, share this, share about your period pain, seek providers that are trained in endometriosis care, and just know that in our clinics, we both see a lot of patients who have spent many years thinking that they either were told like it not to worry about it or like they're just being like sensitive. And once they come to providers like, where we're able, similar to us, where we're able to kind of look at the whole body, they're able to go back and finally get a diagnosis or finally get headed in the right direction. So hopefully this is helpful in that. Roxy, do you have anything else to say?
Well, I just was thinking that I think we live in a day and age where we have so much information in front of us. And I think
Yes.
we also live in a time frame too where it's a little more acceptable to be talking about this. And I think to lean into that in an appropriate way, but just to be checking in with friends or checking in with, Megan and I have daughters. And it's like speaking into the lives of people around us. You don't have to be an expert to just care and just say, how are things going? Or
Yeah.
even, I just think that it's under talked about
Yep.
and it could save someone a lot of heartache or someone, if it's you or someone
Mhm.
around you, just say, man, I've noticed or there's a trend there and I'm just curious, how are you doing with that? And, whether it's a podcast like this or whether it's just, I heard this new thing or whatever, and just be checking in on people and caring for those around you. I think a lot of times if it has been dismissed enough times, then it is invalidated and people aren't then
Yeah.
really pursuing maybe things that they should be if they're feeling a little defeated in that. And so I think just when you had mentioned like talking about it, talking about our periods,
Yeah.
I think there's obviously a little dance there of not like we're not condoning blasting it all on Facebook or whatever that is,
Sure.
but just like
Sure.
with your buds and checking in on people and being an advocate for those or yourself or those around you, I think is a place where we sometimes let each other down, maybe just because we have so much information in front of us that at this point we need to be looking out for each other, I think.
Yeah. Yeah. Just keep the conversations going. And if you have young daughters that have started their period, I mean, one thing that I specifically talk to my daughter about is I say, okay, the pain scale is 0 is no pain. 10 is we need to go to the ER. She's been in the ER before because of a bike accident. So she kind of like she has that ingrained in her head of like what that means, I'm like, hey, when she talks about, like, oh man, I've got cramps. I'm like, oh man, what rating would you give that? And I have her give me the rating because your daughter could be saying like, Mom, I have such bad cramps and it be an 8. And we don't realize that because we use ourselves as kind of the base. Like when she would tell me like, oh man, I've got cramps. I just think about how when I have cramps, I just associate it with myself. And so I make a point to ask her specifics and not because I'm looking for a problem. I'm trying to just educate her on, hey, let me know if that ever, if those get so bad that you feel like you like can't get out of bed, make sure you let me know on that. Okay. And now she knows, she's tough. She'll just say like a 5, give me a heating pad and ibuprofen if she wants it or whatever. But that is something that I think if you walk away and you have a daughter and that she's on her cycle, maybe put that little nugget, tuck it away the next time she's on her period. Just kind of talk to her a little bit more about it and ask like, well, how's that pain feel? Where do you feel that at? Like get curious. So that's my little
Love
2
that.
cents of being a mom with a teen. So
And that's why you're the pioneer, and I'll just follow in your footsteps.
Oh, I love it. Your girls are going to be so well-rounded. I'll mess up. I'll do all the messing up and I'll tell you what not to do. That's what we'll
Perfect.
do.
I'll glean all the
Awesome.
information I can.
That's right. All right. Well, thanks for listening to this episode. And until next time, we'll keep this conversation going. Thank you so much for joining us this week on the Pelvis Project podcast. Help us continue the conversation by liking and sharing this episode with friends. And if you really want to do us a solid, leave us a review. If you'd like to follow us on social, check out the show notes for links. And remember, this week, take a deep breath and relax your pelvic floor.